Ready to go?
Ready to go?
Okay. Hello, everyone, and welcome to our Clearly Aligned podcast featuring the famous and talented Dr. Stephen Schalk, who's a great friend and mentor of mine. I'm Kelley Tyrrell, for those of you who don't know me, a fellow member, and I've been a super fan of Dr. Schalk's for the last few years, ever since he started Clearly Aligned. I think it was a couple of years ago, wasn't it? Two?
Yeah, I think we're coming up on 2 years now.
Yeah, awesome. And today our feature conversation is going to be on the elastic conversation. And we have collected a lot of your questions off our Facebook group and those that have been emailed in. And we're going to do our best to shed some light on that conversation.
Cool. And Kelley doesn't give herself nearly enough credit here because she is phenomenal in what she does as a ClinCheck coordinator, designing cases. She has some of the most intelligent insights that I've ever seen of someone designing and planning cases. So I'm really excited to see her thoughts and opinions on the topics today as well.
So let's get started with some questions from our members. Is there an easy calculation or recipe that you follow to help you decide on the size and the ounce of the elastics that you use?
Yeah, there is. And so as general dentists, we often, I think, get scared of elastics more than we should because it's really not nearly as complicated as you think it is. There's two numbers. There's the size and there's the weight. The size, so most companies use either animals or geographic locations to describe which elastics they have. Obviously, the bigger the elastic, the larger the animal or the larger the city. If you want to break it down though with the actual numbers, kind of a good baseline elastic would be something that goes from the lower first molar to the canine, because that's how we're often going to be using them. And the size that's required then is measuring the diameter of the elastic. And so generally we're working in quarter inches or 16ths of inches or 1/8 of inches. But really, if we think back to basic high school, it shouldn't be too hard to figure this out. So if you're going from the lower molar, first molar, to the upper canine, the size that is required in most of those cases for me is going to be a 1/4 size elastic. And what that 1/4 is measuring is it's measuring the diameter of the circular elastic. So it just goes right across, and then it tells us that that's 1/4 of an inch is the size of that elastic. If you want to go to a smaller elastic, well, 1/4 is 4/16 as well, right? Just times it by 4, because if we want to have a base unit, if we want to go smaller, we go smaller in increments of 1/16. So a smaller elastic then would be 3/16. Smaller than that would be, theoretically, 2/16. Well, 2/16 would also be 1/8. Or if you wanted to go bigger from 1/4 or 4/16, you'd go up to 5/16. So the baseline would be a 1/4 size. And then if you want to go bigger, you'd go 5/16. If you want to go smaller, you go 4/16. And in the show notes, I'm going to go ahead and post a diagram so everybody can see. But if you want to then go from the second molar to the canine, well, I would make that slightly larger. So I'd increase the elastic size by 1/16. So you're going from a 1/4, or again 4/16, to now you want it to be 5/16. If you're going to go smaller, let's say you don't have a canine or you don't have the first molar. So you're going from the lower second premolar to the canine, or you're going from the lower first molar to the first premolar on the upper. So just one tooth shorter, then you'd be going with a 3/16. So a good example of this would be someone who doesn't want to have elastics on their canines for aesthetic reasons. You move it back a tooth to the first molar, premolar, then you could go ahead and just have a 3/16 elastic instead of using that 1/4. Now, there's lots of determinations with if you're starting to get into like triangular patterns or settling elastics, but that's just a good baseline.
Okay, awesome.
And
so in your practice for like a bread and butter class 2 or class 3, where we're like canine to molar, so, just keeping everything completely, normal, nothing fancy. Do you typically start with like a 4-ounce 1/4 inch or like a 6-ounce 1/4 inch? Those are like my two go-to favorites.
Yeah, definitely. The elastic size. So let's talk size a little bit.
Okay.
Weight, I should say.
Weight. Yep.
So a nice baseline again, which keeps it easy, is again 1/4 for the size, and then for weight is 4 ounce. So 4 ounce is considered a medium weight. If you're looking at the weighting, essentially what they do is if you take the elastic and you want it to stretch to be 3 times its size, what amount of weight is required to hang off of that elastic to do it? And so with a 4 ounce, it takes 4 ounces in order to make that elastic stretch to be 3 times its normal size.
Okay,
If
cool.
you want to have a thicker elastic that needs heavier weight, then a 6 ounce is going to be thicker, and it takes 6 ounces to stretch it 3 times. So if this was a patient who was really, really young, we're talking about like an 8-year-old, and you want to start off really gently with them, then you might go with something like a light elastic, which would be 2 ounce. Standard would be 6 ounce. And then if you want to go with something heavier, let's say you have someone who's a huge bruxer and clencher, and they have either, there's 2 terms I'll use, brachyfacial or hypodivergent, just that very strong clencher who has a square jaw. Then I'd often go with something heavier in their case because we know we're fighting against the muscles.
Right.
So you're spot on. That's exactly what we would probably start with, is somewhere around a 4 ounce or a 6 ounce. And then the heaviest that we clinically would use in our office would be the equivalent of a Force 2 elastic, which is 8 ounces.
Right. And do you typically use that 8 ounce like with carriers because you have like something stronger to anchor it to? Or
Yeah.
did you sometimes use it with aligners?
Yeah, great question. So with the Carrier, you can hook up heavier elastics, and that's one of the benefits of the Carrier. But you might just pull your button right off the tooth if you're using an 8 ounce without.
Yeah.
A good rule of thumb that I would say is that Carriers can handle up to 8 ounces or more. You can actually double 2 6 ounce elastics and get 12 ounces. But usually you'd say 8 ounces with a Carrier is pretty standard. With a button, I think that you can comfortably go to 6 ounces. And just going tray to tray and hooking it onto a slit, I would never really go more than 4 ounces because else it will pull the tray off or just kind of bend over that little tab that it's hooked to.
Yeah, and it gets frustrating for the patients because we're telling them like, hook them up, wear them nonstop. And then the precision cut to precision cut, which I fully support. I love precision cuts. But if you get into heavier elastics or a long pull, it can just, that little flap flaps up, and they keep telling us it's slipping off. And we're like, you can do it. Try
Yeah, exactly. Try harder. 100%.
But yeah, we don't want to burn them out. We want to make sure that it's possible. And that's why it's always important to try these things chairside before you excuse them. So if your button's going to pop up, right there before they hit the parking lot or get home. So
Totally.
now, is there a thing as too much force? Is there a danger if like I think doctors a lot of the time or team are worried like, ooh, that's a heavy elastic. Like, what are the repercussions of this? What do you think force wise, irregardless of like what the step size or what we're trying to accomplish?
Sure. Yes and no. I guess in the sense that, am I worried that this is going to cause like irreversible harm to the teeth? Not at all. Unless you were extruding a tooth. So let's say you have a Carrier and the tooth is extruding at the same time that you're using the class 2 elastics, then they could end up biting heavy on that tooth. And it's not the elastic that's doing it, but you're pulling that tooth down and now they're only hitting that one tooth. And I've seen that before on a first premolar where the tooth ended up in a really heavy occlusion. But that was using doubled up elastics where she was biting heavy on that tooth. So we can cover that a bit more in Carrier Week, where we're going to go through that topic.
I agree. I mean, we used heavy. I mean, my husband right now, he's double up crazy elastics with the Carrier, like he's 4 to 6 and 4 to 7. And yeah, he's like got an 8 ounce and a 6 ounce. Like they basically get so chubby on that front hook that you can't fit anything else up on there. But he's a 50-year-old guy, and we got to move things backwards even a millimeter or two, and you got to do what you got to do. I think doctors get nervous when teeth start to get wiggly. Even we see that with aligners, right? As soon as something starts to get wiggly, that's when they're all Facebooking on our chat. Like, oh my gosh, should I slow down? I've got them on a 3-week cycle and I'm aborting mission, and I let them rest for 2 months, and like, we're horrified.
Yeah.
Like wiggly teeth do not bother us. If they're perio-compromised, I mean, obviously, we're watching that closely, but that rarely happens. We like wiggly teeth. And even if it's a Carrier, Carrier, whatever, that, we're using heavy elastics. Yeah, we are used to seeing that extrusion of teeth. We're used to the wiggle. We're used to gaps. For us, that's like, bam, we're doing a great job, like good plan here, making progress. But then, I think a lot of doctors who haven't seen that or are seeing it for the first or second time, when the vampire teeth start to come, like, because they are extruding, they're like, whoa, I'm going the wrong direction. But
it's scary.
Yeah. And so, we learn how to, and we'll talk about that in the next podcast, overcompensate for that, or like cheat it a little bit. But the main thing is we're trying to distalize. So as long as you're getting the bigger movement accomplished, those other little things don't bother us, the wiggly and the extrusion. So I think that's great.
And a good point, just for anybody who's ever wondering about that with aligners alone as well, is when you have brackets and wires strapped to the teeth, it stabilizes everything. So it means that it doesn't seem nearly as wiggly. But when you take off the arch wires in a brackets and wires case, those teeth are super, super mobile. So it's not that the aligners or the elastics are doing anything that doesn't happen with braces. The difference is that you just don't see it. And so I was taught that if you're ever unsure, probe. If you use your perio probe and you check and you know what your original readings are, you should expect that you would have similar readings. And so a tooth could be class 3 mobility, but if you're probing 3s and 2s and 1s, then you know that you still have clinical attachment and the tooth isn't periodontally loose, it's just orthodontically loose. So it's not something to worry too much about. Just keep an eye on it. And one thing you could do is just have the patients eat with their aligners in, because that's going to stabilize things like an arch wire would. It's going to feel very uncomfortable and the patient might not actually do it, but that's one way that when they're occluding and chewing on the teeth is usually when most of the movements are actually happening. So if you can have them eat with their aligners in, then as soon as they finish eating, have them take their aligners out, brush their teeth, brush their trays, and then put them back in again. That's one way to help get them a little bit more stabilized.
Exactly. And I think as long as like the doctors and the teams have confidence, like if the patients are like, oh, is this normal that my teeth are wiggly? Yes, it's normal. Like, even if you're not sure, come back and check with us at the end of the day. But
totally.
Be confident with the patient. Don't be like, let's hold steady. They'll just feed right into that. So just go. I've never seen anything bad in my 20 years, teeth don't fall out. So. So with like the heavy force, is there a certain force, like, is there too much force where you could actually come to a standstill because you're putting too much pressure on the teeth? Like I'm thinking whether it's sequential distalization, like a liner or carrier, is there too much elastic that we can apply? It won't damage the teeth or the bone, but will they stop moving, or is that not a thing?
Well, yes and no. I think that it's very interesting seeing some very challenging class 2 and class 3 cases. What can happen with class 2 elastics with the jaw is that if you hook the elastics up and just think about how your jaw moves. So your jaw is now getting pulled forward. If the patient's walking around, and let's say they're a non-growing patient where you're just trying to like sequentially distalize teeth. If they're walking around with their jaw sticking forward, then the elastics aren't actually stretching. They're not actually pulling on the teeth because their jaw's so far forward that, again, remember that stretching the elastic to be 3 times its normal diameter?
Right.
If they're not actually stretched because their jaw's coming forward and the elastic's not engaged, they're just walking around caveman style and nothing's actually engaged. And so I look at the patients when they come in and also when we're doing the instruction with them to tell them, I don't want you to stick your jaw forward. We're not doing something like a mandibular advancement tray with Invisalign where you're trying to rely on their growth to change things by having their jaw positioned forward. Instead, we need the elastics to be fully stretched and engaged. And what's interesting then is that class 3 cases are actually really, really consistent when the patients are using their elastics because you can't force your jaw really to go any further back. I mean, of course, your joint could be posteriorly positioned and cause pressure on the retrodiscal tissue, which is a different topic. But you're not going to really... you're going to get results. And so I find the results that you get with class 3 cases are actually way more consistent and faster because the patient can't posture their jaw.
Okay. Oh, that's a good point about posturing forward.
So that's why I think sometimes if the patient, if they're not a strong muscled patient and you use too heavy an elastic, then yeah, they're just posturing their jaw. It's someone who has, again, that strong facial type where they're kind of fighting the elastic, then the extra strength from the elastic makes sense. If
Okay.
not, then I kind of stick with that medium 4-ounce elastic still.
Okay. Does the particular age of the patient or the amount of step, like if it's a quarter step, half step, or full step class 2, weigh into you starting with a 4-ounce elastic versus a 6-ounce? Like, do you go hard and fast right off the bat just because you know you have a full step, or do you just always start at 4.5 and only edge up or change strength if you're not seeing progress?
I'll normally start off with a 4-ounce and then probably step up if we're not seeing progress. Unless it's maybe like that full step, like a full step class 2, I would not generally be looking to do using just elastics and aligners. I'd probably be looking at doing a Carrier. That's where I would draw the line. The other thing to look at, there is for sure different things about the facial balance, whether you're going to intrude teeth with the aligners while you're sequentially distalizing to try to get the mandible to swing forward.
Okay.
And so you don't want your elastics to be overpowering the intrusion. So let's say you're trying to intrude the second molar, then the first molar, then the second premolar, first premolar, etc. And then on the lower, you're intruding the lower incisors, canine, and first premolar. Well, the reason we're doing that is because all of that intrusion then means that you're actually creating a posterior open bite on the top in the back.
Okay.
And you're creating a bit of an anterior open bite in the front on the bottom. And what that does then is it's causing their mandible to kind of swing forward. But if you have super heavy elastics that you're using, say from the lower first molar to the upper first premolar, you could end up extruding some teeth that we don't want to extrude because the elastics are too heavy.
Right. So you're fighting yourself.
You're fighting yourself because you're trying to correct not just what the anterior posterior changes, you're trying to correct also by changing their vertical dimension and causing some auto rotation.
Okay. Yeah, I could see how that we're coming back, the patients, we're checking them and we're like, are you wearing those? And we're like fighting ourselves. And,
Totally.
you know, these are things that we learn over time. And I also think, you know, like with switching elastics, which we're going to talk a little bit more about later, but yeah, like easing up to heavier elastics, we're also trying to help the patients get done the elastics as soon as possible because they do get burnt out. So, you know, they're excited about their treatment right off the bat, and, you know, it's a partnership and we kind of get their buy-in to help us out with the things that we can't do by ourselves. But at a certain point, they're done, like, and we know it, and we can try to motivate them into action different ways. But, you know, you really want to start off energetic and get it done and helps them finish it. And, you know, you don't want to keep giving them breaks in the middle unless you're there, because again, you're getting in your own way. But, you know, the sooner you can be done, the better. And I mean, by soon, I don't mean like 12 weeks. I mean, these are significant cases. So we need time.
The other thing that I think, and I'll get your thoughts too, Kelly, but what I think is so important is to also make sure the patient truly understands what's involved with the elastic. So if I have a full step class 2, they have a 6 millimeter overjet on an adult, I'm going to be telling them that, like, the reality is you're going to be wearing elastics for 18 months, 20 months. I can get your teeth straight sooner. But the elastics, because you're not a growing patient, if we're going to fully correct this, it's going to take time because we're moving a lot of roots and a lot of teeth. We're not just going to be straightening and aligning teeth and then ending up with a large overbite. Well, I say overbite for the patients, but I really mean overjet, of course.
And I think that's like, I think you're the same. I like to put like a bite jump at the end because, again, I always show my patients their clinch checks, even if it's overcorrected and it looks crazy. I just explain it. The more they know, the better they help me out. I figure I tell them their key attachments. It's a lot, but you know, they're my partners in it. But I like that jump at the end because I say, this is what we are going to do. This is what we can achieve all by ourselves. And your part is this elastic part. I can't help you with this. I can just give you the right elastics and encourage you and track you. So if you don't do your part, this is where you'll end up. This is the overjet you'll have. And if you're happy with that, you know, that's fine. And sometimes we do have that conversation towards the end, like, okay, you know, it's been 18 months and we've been struggling with these elastics all the way. We've made some progress, you know, we do make progress. We always put a positive spin on it, but, you know, am I going to hold them hostage for a whole nother year when everything is finished. Sometimes we've even placed their lingual wires because we don't want them to stop wearing aligners. We place their bars and they have, retainer, basically full-time retainers with elastics, and they're still not doing it. And so like, why?
Yeah.
Just stop. And, sometimes we have a conversation of, because we do have warranty periods and things like that, we say, you know what, if you decide in whatever the magic number is, a year from now, you want to fix that last little bit and you can do it. It's elastics. There's no magic. It's elastics.
Totally.
Then come back to us and we've got you. But there's an expiry date on that, of course, because we need the aligners and we don't want to pay for more and et cetera, et cetera. But again, you just want to be conscious that they're human beings.
Yeah, I like that. I agree 100%. I think a huge takeaway for anybody watching this, listen to what Kelly just said, was your partners with your patient in the treatment. And there's a certain limit to how much they have to give in their tank. Mm-hmm. And there's a certain point where it makes sense to say, are you done? Are we finished? Mm-hmm. Because if they haven't been wearing their elastics for 12 months, they only wore them for the first 6 and nothing changed, are they realistically going to be able to keep wearing the trays and the elastics for an extra year when their teeth are perfectly straight? Yeah. And there's certain aspects of growth, because I think Kelly's probably also talking a lot about growing patients with the bite jump, that the bite jump is just showing how much growth is possible or how much of a simulation is required to get them from a class 2 to a class 1. In a non-growing adult patient, that bite jump at the end, and I love that too because I do the same thing. If the bite jump shows more than maybe 1.5 millimeters to 2 millimeters, then that's the maximum amount you can probably get in an adult. Mm-hmm. And so then you need to use other techniques like the Carriere, like sequential distalization. But yeah, for those, I don't do that, but I think maybe I should start doing it for my growing patients to show them, look at this change at the end and show them that bite jump where it shows the jaw jumping. Well, it's the lower jumping forward to show them this is the elastics. If you don't wear your elastics, then you're going to be left with this huge overjet. Mm-hmm.
That's good. That's good.
I like it, Kelly.
There was something else that I was, slipped my mind, something about that. Also, so for elastics, I mean, we've gotten into, or at least you and I have gotten into this, we stretch our chair time is like golden, like we're very competitive about chair time and whatnot. So, we started checking our patients probably every 6 weeks, and then 8 weeks, and 12 weeks, and 16 weeks. And some patients we deliver and we don't see forever. I mean, we're virtually watching them. But again, we've got confidence because we have a lot of experience, a lot of years behind us. So, we're not nervous. I don't need to watch the grass grow if I know it's a good plan. And of course, I'm not an orthodontist, so they're not officially my plans. I'm just like a team member. But full disclosure. But how often would you say when we're using elastics, you should check in on the patient, especially most of our doctors possibly who are on today or listening to the podcast are new. So they are a little bit more nervous. And what should they be looking for? Like, should we definitely check them every 8 weeks or 12 weeks, or even if it's virtual, and what do they want to look for?
Sure. Great question. I think that the first part is probably understanding how the elastics work. So we talked about size and we talked about weight. The other thing then is how frequently should the patients be changing their elastics and how much are they wearing them? And for my patients, I either have them on 2 protocols. One, if we're just doing minor things, would be nighttime wear. The other is full-time wear. And then in terms of how often do they change the elastics, we have them change, I say 5 to 7 times a day. So I tell them first thing in the morning when you wake up, when you have breakfast, lunch, a snack after school, dinner, if these are, usually we're talking growing patients here, sometimes adults too, but after dinner and then before bed. And so if you add those all up, you're looking about 7 times a day. So anytime you take out your liners, you should put in fresh elastics. So we give them, the elastics come in baggies of 100 elastics, and we'll give them like 5 to 7 baggies. And if it's someone who's really like not compliant at all, we'll tell them every 2 hours, change your elastics every 2 to 3 hours even, because you want them to still have that stretch. If the elastics are really worn in, I once had a patient, you'll like this. When I was first starting, we didn't tell her that she needed to be changing her elastics, that they were disposable. So she came back and she was so proud that she'd been wearing the same pair of elastics, the same set for like, I think she had to come in for a button came off or something for like 7 days straight.
They're like orangey
Yeah,
brown,
they were
just like
disgusting. It was amazing they were still
spaghetti.
together. They had no stretch at all. So that's the other
Oh
part of
God.
it. So when determining with these patients, we try to customize them towards what they most need. We use dental monitoring at the office like you as well. So when looking at dental monitoring, the goal of doing like virtual at-home monitoring is not necessarily to reduce the number of appointments to as few as possible. It's trying to tailor their treatment to what they need. So an excellent patient who's doing phenomenal and following the instructions, we might not see them until every 3 to 6 months even. But someone who's non-compliant and needs those accountability checks, we'll actually have patients coming in as frequently as 2 to 4 weeks.
Okay.
So a good answer would be if it's a patient who's compliant and you have a long ways to go with your elastics, we'll load them up and we'll see them back in 3 to 6 months. But if it's somebody who's not good and we need to check in continuously with them and really see in person, when you ask them those questions eye to eye, are they lying to you? We'll be bringing them in like maybe once a month.
Okay.
And I like doing that with my carriers. We're jumping ahead here, but I like bringing in all my patients back at the 1 month mark. And so if you were new with elastics and you weren't sure if your patients would wear them, I would bring them back at the 1 month mark and really face to face explain again how important the elastics are. And then ask them again, out of 10, I like this one, out of 10, 10 being you are perfect, 0 being you didn't wear them at all, what score do you give yourself? Right. And I feel like you can always take a couple points off if it's in the middle. So if somebody says they're a 7, they're probably more like a 5. Everybody inflates it. But if they say I'm a 9 or a 10, like I'm nearly perfect, that's probably truthfully the situation.
Yeah. I think to a certain extent, we tend to blame a lot on the patients. Like, my team members, like I hear it in the communities, like co-op and patient compliance. And sometimes it is like our planning. So we have to take some accountability, or sometimes we rush them through that first new patient appointment, bonding and IPR, and we got a lot to do. And so, maybe we didn't fully, do our full motivational speech about elastics, so they don't understand. Definitely with carriers, I tell them, like, when you come back, so whether it's 4 weeks or we tend to do 8 weeks, this is what I want to see. You should have a gap between the tooth. I'm going to wiggle that bar and your tooth should be moving, et cetera, et cetera. So those are and your teeth get longer. So I'm looking for vampire, gap, and I'm going to wiggle the bar. And if you don't have those things, and I'm not expecting a huge gap at 8 weeks, but I'm expecting something like a loose or open contact. And if you don't have those, I know you're not wearing them, maybe not as much. You might think you're doing, a great job, but we need to up it. And they tend to understand that. And I basically just tell them, especially with carriers, if you're not wearing your elastics, that's just a shiny decoration on your teeth. Nothing is happening, and you're buying yourself 4 or 6 months of more treatment. And we will order a whole nother set of lower aligners, let's say for class 2 carrier, to give them a second shot at being motivated. But after that, we call it and we sequentially distalize. Again, sequential distalization, still elastics.
Yep.
So,
exactly.
But we take a little bit, I think with sequential distalization, you take a little bit more control back, because as soon as you get that plastic wrapper on the tooth, I feel like I've got I'm helping them a little bit. But they need to be participating, and again, changing them often is key. Keeping it fresh and changing.
Without that compliance, I agree. You're not going anywhere. And I like to tell them too that elastics are one of those things that, and I just kind of make up these numbers a little bit, but I tell them for every hour you have your elastics out, that means 4 hours of your previous progress is gone. And if you have them out for too many hours in the day, like the entire day's worth is not useful. So if you have them out for more than 4 hours a day, you might as well write that whole day off.
Yeah, that's what I say. I'm like an exaggerator, in case you guys haven't picked up on that. So with my patients, I always whether it's like a liner or even braces, any kind of elastic wear, I pretty much tell them consistency is key. It's not so much about the force, because sometimes you'll have patients saying, can you give me stronger ones then? And I'm like, it's more about consistency. We've already given you as strong as we feel comfortable with. So it's like pushing a medicine ball or like a bowling ball up a hill. you wear them, you're taking them out like just to eat or to brush. So it's not long enough that the ball's rolling down the hill yet, but you're keeping that momentum up. And the goal is that we reach the destination and I take away the elastics and you're happy and I'm happy and I can finish the rest of the case. And now this pressure's all on me to finish. But if you keep taking breaks, whether it's, I don't wear them to school, but I'm really good after school and nights, that we hear that all the time. Basically, I tell them, like, there really is no point. I'm not saying they're not making a little bit of progress, but I don't tell them that. I say, we need that consistent wear 24/7 to get that ball to the top of the hill. And every time you take off the elastics, that ball runs down to the bottom of the hill and you're starting from scratch again. And they seem to really get that consistent pull up the hill. And once you're there, I'll tell you, the minute you've reached it,
you're done.
I will pull it.
Yeah.
So, yeah. And we do that with carriers too. I mean, as much as we planned, usually like a lower arch of, let's say 24 weeks of alignment. If we've had like an Olympic wearing elastic kid and, in 14, 15 weeks, they have corrected their class 2. I don't really let them sit there with just night elastics and get through the rest of their trays. I could, but we scan it and we celebrate it by removing the carrier. Like, they want to move on. They want full aligners, and that's what we've set them up for. So once in a while you will get those kids, or sometimes adults, but adults can't move as quickly, of course. Reward them by also moving quickly. Don't then make them wait 8 weeks to get their next bit of alignment. Bring them in.
Yeah, that's a really, really good point. Like, the motivation aspect with these teenagers and kids, if you're getting them to their final position, then I like to show them examples of other kids who've been in treatment and say, oh, this one was the same length. It was supposed to be 18 months, but he actually finished in 12 because he was so good with wearing his elastics.
Yeah,
and that's what I'm hoping for you. I'm going to tell you 18 months, but if you're amazing, you might be done in 12.
Exactly.
Yeah.
Now, if you had a patient, like, you're monitoring them, we see this a lot, which is why I'm bringing it up. So you've got your class 2 correction, and then their lower jaw drifts forward. So they have that like bulldog look. We know that the jaw is movable, but you see them back in your chair. Maybe you let them go 8 weeks, 12 weeks, or whatever it was, and they bite together, and you're looking at the class correction, and you're like, holy crap, I've made them like in an anterior cross bite. Like, all the doctors who just started using elastics go crazy. So what do we do? What's the fix? Is it a big deal?
So I guess there's 2 parts to this. There's 2 approaches. One is that in a lot of these cases, sometimes what is happening is, and this is something to be aware of with the class 2 correction in a growing patient, sometimes if you are using class 2 elastics, the patient, whether it's a true muscle splinting, it's hard to say, but they're almost like muscle splinted forward. Okay. So it's really important not just to say, hey, bite together, and then you look and they're edge to edge. You want to try and like observe them. I like looking when they're talking, because sometimes I'll have these patients who, when I get them to bite, they bite class 3, but then when they're talking, I see that like their teeth are almost coming together when they make certain sounds when you look at them, and they're in a class 2. Okay. And then I'll say bite, and then because the elastics have been pulling their jaw, they're like either full class 3 or they're still a big class 2, but they're doing a functional shift. They're just sliding their jaw forward into a class 1. Okay. And that has gotten me before. I'm sure it gets everybody at some point, where you're like, sweet, this looks amazing. We're done with our elastics. Yeah. You take them out of elastics. You see them 6 months later. You finish the case and you get them to bite for their final photos, and they're still 3 millimeters class 2. And you're like, well, your last pictures, you were perfect class 1. Well, they were kind of muscle splinted or functionally shifting, and we didn't catch it. Now, I guess truly, if you wanted to know, you could take a CBCT of their condyle and you'd see exactly where they're positioned. Normally, I just feel like a little bit of pressure on the chin, get them to try and swallow their tongue. Yeah. And then get them to bite and see if you can evaluate that. But so those patients who are often in class 3, that's the first thing I look at too, is put your tongue to the back of your throat like you're trying to swallow it, a little bit of pressure on their chin, try to keep them relaxed, get them to bite down and see, are they actually in class 3? Right. A lot of times, if they jump from straight class 2 and usually like a significant overjet, and I've had this before, to then like big class 3, the other thing I'll get them to do is can you stick your jaw out any further? Stick it out as far as you can. And I don't have the numbers here, but I think you're supposed to be able to protrude your jaw about 1 centimeter. Okay. And so if they're like out here and then you're like, stick it further, and they only can make it like 1 millimeter or 2,
Okay.
you know that it's probably that they're muscle splinted or posturing. In
Okay.
which case, I would go ahead and just be like, let's stop the elastics for 2 months, see you back.
Yeah.
And a lot of the times they're out here, and then now they're back into their normal biting position. They're in a perfect class 1. Because you don't want to necessarily just go ahead and strap up some class 3 elastics, but
No.
they're
Yeah.
muscle splinted, and now you've gone ahead and pulled them back to the class 2 position, and you're just like missing the target. So it's recognizing when they're posturing and recognizing when it's real. And I feel like most of the time, if they end up in edge to edge or class 3, it's posturing. So I almost always stop for 2 months. And then if they're still in class 3, then I'll go ahead and do some class 3 elastics, but I'll do it really light. So I won't go with like a 4 or a 6 ounce. I'll go with maybe like a 2 ounce. And then I monitor them real closely just to see. I won't give them as much time. I'll go for maybe like, depending on how close we are, like 2 weeks or 4 weeks or 6 weeks, but I wouldn't go for like 2 months or 3 months.
Okay. Yeah, I'm the same. Sometimes, when those patients come back and like, it doesn't bother us at all in ortho. I mean, we see them all the time. But, if they're too far, I don't want to lose momentum. So oftentimes we'll do the same thing, keep them in night elastics so that we're kind of still moving, but taking baby steps in the same direction, because knowing we probably still have class 2 to correct, or we know we still have class 2 to correct, but it's unnerving. The mother at the end of the chair of the growing patients are like, oh, is that right? Yes, all good. Actually, you've done an Olympic job on your elastic. I'm like,
we always want to overdo it a little bit, right?
Exactly.
Like, it's
and
great. It's perfect.
Yeah. The moral of the story is don't overreact, don't oversteer. Yeah, don't do the class 3. Let them drift back, let them settle. And again, you can keep them at night, or if you're really worried, you could stop for a month and then tell them to start on the next 4 weeks of just night elastics, and we'll work our way back, and and you let them know, let them in on the secret. Hey, you did a crazy great job. Now we're going to let it settle back again, and then we're going to get restarted with the elastics. So you're not done. It's just like a vacation. And then, but these are normal things that we see all the time. So
exactly.
That's good to know. Now, how much pull, I think this question that was sent in, how much distance or pull are you looking for? We kind of touched on this, but standard, we do canine to first molar, that's standard. So if you're going to hide that hook, let's say, we do that sometimes for aesthetics, or if they have a retained primary canine, you don't want to pull on that guy. So if we back it up, 4 to 6, the shorty, you're not going to correct a big class 2 that way. So you got to make some adjustments, right?
Yeah, unless you're, again, it kind of depends on if you're, and this is getting into like quite advanced stuff, but are you trying to change the vertical while you're intruding teeth with the aligners or extruding teeth with the aligners for a class 3? So like, here's the good way of thinking about it. If you want somebody to swing further forward, you would potentially intrude those upper molars and premolars, and then intrude the lower incisors, and that causes their jaw to swing further forward. Because the more that you kind of close their bite, the more their jaw comes forward. The more you open up a bite, I don't know if you can see me well in the video, but as you open up a class 3, their jaw swings back while that's happening, and so they end up in more of a class 2 situation. So if you open the bite, they become less class 3. So for example, like when I'm doing my class 3 elastic cases, I'll often actually run shorter elastics. And I'm trying to extrude the teeth with more like shorter vertical elastics. If I'm going from like the lower 4 to the upper 6, I want the 4 and the 6 to extrude, because then it kind of causes a premature contact in the posterior and it opens them up a bit. Now they have a bit of an open bite in the anterior, so we still have to then do some extrusion of their anteriors after that. But their jaw kind of swings backward a little bit.
And then for that, would you use a 3/16, like a shorter, like, would you,
like a shorter,
correct me if I'm wrong, I hate
heavier
numbers.
Yeah, no, you're right on
numbers.
Right on.
I'm more into the I have a lot of elastics on my desk. I have, the countries of the world, the animals of the world, forest creatures. That's all the fun that we have in ortho is changing.
That's all we get. No, it's so true. Yeah, but I would use something heavy, because you need a stronger force for extrusion to occur, and something that's less horizontal and more vertical.
I don't. That's something that's new to me. I don't often. When I'm doing elastics, I'm mostly thinking AP. I don't often think of the vertical. That's why you doctors.
Well, this is something that I don't think a lot of people do think. This is like courtesy. I need to give credit where credit's due, 100% to Dr. Tarek Albiali, because he's the one who thinks outside the boxes with things like how do we change their vertical to affect their anterior posterior. And if we can do that, then it's not so much the elastics pulling the jaw forward. It's more like the things that he's doing is those skeletal changes through controlled intrusion and extrusion, because we know the aligners are so good at those movements. But then the second thing is that he's actually doing some stuff where he's actually trying to get the mandible to pull forward if they're a significant class 2 in a non-growing adult and hold them in that position and actually achieve condylar remodeling. So the condyle, or the fossa, I should say, is remodeling because the condyle's positioned anteriorly and being held in that spot. So there were some studies that he was looking at out of Japan where they were remodeling condyles to rather than doing surgery. So it's kind of a combination of that intrusion extrusion to get the jaw to swing forward, and then if you don't have any more of that position, the condyle, and then over enough time it can remodel. Now I'm not an expert with that, so I can't speak to how well it works or doesn't work, but it's a really interesting way to think about things.
Yeah, that's awesome. Interesting. Okay, so that is great. That's perfect. I did want to know about that. These short elastics. So I learned something there. And now I'm a little bit worried about my husband. I'm like, am I elongating his already oval face? But it's too late for him. That plan has sailed. I didn't do it by myself. Help to me. Okay. So I think, how about this? This came in from our members. What elastic strength or brand, and again, this depends if it's short or long, do you prefer or recommend for sequential distalization? Is there a difference that or do you just, it's your standard?
Sorry, you're asking which brand to use?
No, which strength in particular?
Okay.
Brand, because the brands are they're pretty much all measured.
I'll actually touch on that first. The only brand that's any different that I would say is if you're using super heavyweight elastics. I know that Dr. McNamara did a study and he found that the weight of the Force 1 and Force 2 elastics, they're Henry Schein.
I got those here too.
Yeah, I love it. That they produce a stronger amount of force to stretch. Like they don't meet that rule. They're actually stronger than the kind of the 3x expansion of the diameter. And so Force 1 and Force 2 elastics, if we're using really heavy, that's what we try to use unless there's a latex allergy.
Yeah.
But in terms of like a sequential distalization, again, I'm probably using depending on the size, because if I'm going from the molar on the lower to the upper canine, I'd be using something that's like a 1/4.
Yeah.
And then it would either be a 4 ounce or a 6 ounce. If I needed to go from the 6 to the 3, or to the 4, 1 tooth shorter, then I would do the same thing. I'd be going with like 3/16. So just 1/16 smaller.
Okay.
And then kind of the same weight, either a 4 ounce or a 6 ounce. And we're similar. We have like 1,000 different size elastics for different specific situations that you come across once a year.
Yeah.
And so we have like half weights, like we have like 3/16, 4.5 ounces.
Yeah.
3/16, 5 ounces. But a good rule of thumb for somebody who's just starting is if you have 2 ounces, 4 ounces, 6 ounces, maybe
an 8 if they have carriers.
Yeah, 8 if you have carriers. And then where it gets interesting is kind of like a midline elastics. Like sometimes we'll use elastic from the upper canine to the lower canine across the middle on opposing quads. So from like the upper right to the lower left. Then you generally need like a 5/16. It's just like the size
it's a longer
of what you need
stretch.
to pull. So it's a longer stretch and it's kind of uncomfortable. You only usually use it at nighttime.
Hannibal Lecter elastics. That's what I call.
Exactly. So maybe like some 5/16. And you want it to be lighter, so like we use like 3 ounce or 3.5 ounce, 5/16.
We try to keep that to after work, after school. Although COVID was really great for the anterior.
Midlines were getting aligned like never before.
Yeah, it was awesome. Speaking of sequential distalization, without getting too into the weeds with it, so with sequential distalization, obviously we're going 7, 6. Sometimes the 4 and 5 together, and then the 3. Do you start your elastics on that day 1 insert when the 7s are distalizing? And obviously there's alignment going on, or do you wait till that magical period, whether either the premolars are starting to move or the canine?
Yeah, so I like doing mine where I do like 7, 6, 5, 4, 3. Those are all individual. And
Okay.
then the only thing that I have moving together as they back up is the like laterals and centrals.
Okay.
Um, and I do start my elastics immediately. The reason
Okay.
that I do is that kind of think of it like we're having like a tug of war, so to speak. So we're trying to like, the 7 is moving backwards, but as the 7 or the second molar is moving backwards, it is
Mm-hmm.
pushing against the anterior teeth a little bit. It's very small, but let's say that we back up the 7 by like 5 millimeters.
Right.
The anterior segment, the 6 forward, is moving forward maybe like 0.3 millimeters, something very, very small. And then as the
Okay.
6 moves backwards, the anterior segment might be moving 0.5 forward, and all those teeth are slightly moving forward.
Just because it's the opposite force. We're
It's the
not doing
opposite
it
force.
intentionally. We're just that it has to dissipate somewhere.
Exactly.
Okay.
It's kind of like, say, you have a 5-year-old sitting in a computer chair, and they're sitting against, opposite them, there's someone who's like 200 pounds, and the 5-year-old pushes against the 200-pound person. The 5-year-old's going to go flying back, but the 200-pound
Right.
person's still going to move maybe like an inch.
Oh, good analogy.
And so
Yeah.
I feel like we want to, so we call it the anchorage, right? We want to
Okay.
control the anchorage. Now, friction in real life prevents that from actually happening. Eventually, you'd reach a limit that if someone's 1,000 pounds, they're not going to move at all.
Right.
But and that's kind of because of the friction of their chair against the ground. But just like how we always say that the earth has an impact on the gravity of the sun and the sun on the earth, well, the sun is much stronger. Or that
Okay.
we have an impact on the gravity of the earth as individuals, but it's a minuscule 1/1,000,000th of what the earth has on us as an
Okay.
individual. So it's the same thing with the teeth. So I normally do like starting the elastics immediately for 2 reasons. One is that, and the second is I want the patient to get used to wearing those elastics right away,
Yeah. True.
and kind of just get used to it. Like, we might as well just start and get it going. If they struggle with the elastics, I tell them, don't worry about it. If you can't get them, we'll see you again in like a week or 2 weeks. Let us know. We'll go ahead and do some more practicing. Even if you can just get them at nighttime for the first week or 2 weeks, then that's great.
Okay.
While you get going, but I do need you to be wearing them all the time. And I prefer for you
Okay.
to wear them from the beginning. But if an 8-year-old kid or a 10-year-old kid is having trouble wearing their elastics, I don't want it to ruin the entire experience and then they think aligners are terrible. I'd rather just go ahead and say, keep it pretty easy, wear them at nighttime, get used to them, and then let's go ahead and make sure that by the end of the week we're wearing them all the time.
Okay. Awesome. Okay.
Yeah.
Sounds good.
Oh, sorry, just to finish that then with
Yeah.
sequential distalization. So what I do is I have them move the 7, and then the 6 doesn't start moving till the 7 is halfway finished moving, then the 6 can start moving.
Okay.
The 5
too.
doesn't start moving till the 6 is halfway finished. So my
Okay.
goal is to always have only 2 teeth moving at a time. So the
Okay.
7, and then halfway through the 6 starts, then the 6, for the first half, the 7's moving, and then for the second half, the 5 is moving. Then for
Okay.
the 5, the first half is when the 6 is moving, the second half, the
Okay.
4 starts. And then once it gets down to the incisors, then I let them treat the incisors all together the same. But the reality is that this adds treatment length, because you're
Yeah.
looking probably at like 70 aligners in order to do that. So sometimes I'll cheat and I'll tell them, okay, don't do that because I don't want 70 aligners. But the reality is that sequential distalization, if it's a significant amount, it's gonna
take
takes time. If it takes a
Yeah.
year and a half with a carriere, it's probably going to take 2 years with sequential distalization. I always say 6 months longer than whatever the carriere can do is what sequential distalization would take.
Okay.
If the sequential distalization can actually even do it, because sometimes there's cases where it seems like there's too
Yeah,
much
it's not
movement,
going
it's too
anywhere.
hard. In that case, if you're going to do it, you need something like a TAD-based appliance.
Yeah. 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 But both, I mean, sometimes no matter what you do, carrier or sequential, you're just, patient. Like my husband, perfect example, like he's been epic with these elastics. It's actually embarrassing. Even at restaurants, he literally will take them out right on the spot. Like they are only out of his mouth if he's chewing. So I'm like, people don't do that socially. I'm like, I forgot to go over the etiquette, but he's like full time. But it's slow. It's been, and we even got his wisdom teeth removed. Like we don't usually do that in ortho. We don't, apart from class 3 distalization or whatever, we don't typically ask for their wisdom teeth out at the beginning. We leave it to the end because that might be an obstacle to them starting with us. But even my 50-year-old husband, my ortho, was like, I think we should get those out. And I'm like, really?
Yeah.
Special treatment for Rob. But so he did it. He's trying to, but anyways, it's still slow, but we're trusting the process. And I do sometimes, I have in the last year or so, tried to move the 4s and 5s together as a unit after moving the 7s and 6s. So we'll see. I don't find tracking's a problem, but yeah, it's just actually getting the full correction, which we're happy with some correction. As long as the anteriors end up okay, as long as it's functional and we don't make it worse, no one's going to ever know. He didn't even know he was a class.
And I definitely can say too that sometimes I do have the premolars moving together. There's no hard and fast rule. It depends on how much sequential distalization is needed. In my opinion, if it's going to be a smaller amount, then you can have more teeth moving at once. If it's going to be like a really significant amount, then that's the situations where I realize it probably matters more.
We just have a couple more questions left. So another one was, when do you decide on nighttime wear? Like, when do you make the call on whether they should wear nighttime? And also maybe for those, I know a lot of us in your group are doing like mixed dentition, like phase 1, phase 2. Like, are you holding them hostage in nighttime elastics for years?
I would say I'm freeing them from daytime wear. No, but normally nighttime wear, if you have an adult patient, if they're not wearing their elastics all the time, nothing's going to happen at night. There's no point really. Other than sometimes if someone has a really tight bite, like they're kind of class 3, I'll plan some class 3 nighttime elastics just to kind of keep them from biting right on their anterior teeth pretty heavily. Okay. Or this is a good one. Let's say you have someone who's class 3 and you're going to be correcting it mostly with IPR. So you're doing some IPR between the bottom teeth and you don't do any on the top. When you close that IPR spacing, some of that is going to come from, well, most of it will come, if it's in the anterior, from the anterior teeth retracting into that space. But a little bit of it could be from the molars shifting forward. So let's say you're doing the IPR between like the 4 and the 5, or the 5 and the 6 on the lower. In my opinion, it's super important to then, if it's really tight, and if you're fighting for like every millimeter to get them off that edge-to-edge bite, put them in class 3 elastics, either full-time or if you think they're going to be too opposed to it at nighttime, to try to make sure that all that space that you did the IPR for, that it closes with the anterior teeth moving distally into that space, not with the molars drifting mesially. Else you might do like 0.5 millimeters of IPR between every contact. So you did like 5 millimeters of IPR, but you only got 3 of it with the anterior teeth retracting. 2 millimeters of it was the posterior teeth mesializing.
Right.
So that's one reason to do it. But other than that, if it's like a class 2 adult patient, nighttime wear is kind of useless. With teen patients, it's usually if I get them close enough to their target destination and it's like the last millimeter or something like that, and I know we still have a while that we're going to be in treatment, then I will normally say, let's go with nighttime just to like finish the tweaks. Or I'll use an elastic. If I need one side to move full time because it's worse, then I'll have them wear the one side full time and the holding side nighttime. Yeah. A follow-up, a lot of people ask, would I ever have someone wear just an elastic on one side and not on the other? And I do. I know some people say that there's an increase of possibility with TMD. I haven't really ran into that issue. So I will have them just wear one side unilaterally. But
like for a midline shift or a carrier, a carrier, they have a 3/4 aligner. So we're not really too worried about much of anything.
Yeah. So I do that. So, but with these kid patients, really, and this is a whole nother topic, like mixed dentition patients are so fun to treat because you can do anything almost. The patients are super compliant and you've got 5 years to do it. My goal of mixed is to do 1 year of full-time wear. Normally, I don't use elastics on mixed dentition in that first year unless they're a significant class 3. I'm just trying to expand the arches, correct the curve of spee, level and get everything in the proper spot and give space for new teeth erupting. Then I'll go ahead and use elastics or the mandibular advancement feature just at nighttime. Because then it's really easy for them to just wear their elastics at nighttime. They're not getting as much benefit because they'll lose the stretch of the elastics halfway through the night. But we've got 3 or 4 years of just doing nighttime. And then if we need it, like let's say they start when they're 8, or 9, maybe by the time that they're 12 or 13, now if we need some serious anterior posterior correction with elastics, now we put them back into full-time wear, even though their teeth are perfectly straight. We're doing it just for the elastics when we hit their peak growth.
Yeah, that's great. That's a good point. Do you have a preference, or maybe it's case specific, for precision hooks versus window cutouts, or what you prefer to bond?
Generally, I like button to button the best, because I feel like what happens when you're hooking to the aligner in some circumstances is the aligner is getting pulled off the teeth. So the aligner becomes less effective. If I have a patient who's from out of town and I'm worried about buttons falling off, I always do hook to hook.
Okay.
Because then they don't need to drive 6 hours to literally have us spend 10 minutes to put a button back on.
Right.
If I have a patient who has really small teeth, like a mixed dentition case, it can also be really hard, because if they're losing teeth and they're small, so there's not a lot of retention with the trays, then you go hook on the teeth, you end up pulling the aligner off their teeth, and then it doesn't do anything, and the parents get frustrated because then things stop tracking. So that's also why in the mixed dentition cases, I don't start with elastics usually right off the bat, because I want to get the teeth all lined up properly first.
Yeah.
And then I'll usually do button to button still, but I do a light elastic, because I don't want the teeth to extrude from having a heavy elastic, because those mixed dentition teeth are so movable. But if I was wanting to do kind of like what's the kind of the downside of the buttons is they bite down on the candy cane and they break off their button. So you can end up with a lot more chair time. So the decisions are this. You go button to button, which is probably the best for the clinical results, because it's not pulling the aligner off the teeth.
Right.
But it's the most chair time because the buttons can come off. The flip side is going liner to a liner is way more convenient for us clinically. It's a little bit harder for them to get the elastic on the bottom distal tooth, so the lower molars. But it's not maybe clinically the best, because it's dislodging the trays. The sweet spot sometimes then is going ahead and doing a button on the lower first molar to a hook on the upper canine or first premolar.
Because and have like an attachment to anchor it and to make sure it doesn't flap off.
Yeah, and then a big thick attachment on that tooth. Exactly.
Sometimes I've been as backup, because again, for the chair time, we do have hooks that pop off a lot. It's, oh my God, it's a lot. It's like it takes little red squares all throughout the day of emergency, but sometimes they barely made it to the parking lot. But so hook on the 6, and then I build in a precision cut on the 7, and that's like the emergency backup, so that they don't have to use our chair time the same week, whatever. We can take our time, or if it's close enough to their appointment. Again, they might have to back up the strength of their elastic if it was a 6 ounce, but you can do it. So sometimes we'll even do
some time.
Yeah, and even with a carrier. Button on the 6, because I usually do canine, button on the 6 and a slit on the 7, just so they don't lose momentum. Like, what if they can't come back in a week or two? You're going to lose what you've gained. So,
and we're playing this game. Used to then not wearing elastics and get kind of lazy.
Exactly.
Yeah, and of course, I love that too.
And you're great about having pictures of your favorite hooks and things that stick. And, there's so many options out there, but it does take some trial and effort. Like, we have a whole button buffet from Asia, from everywhere. Like, which ones stick, waffled, non-waffled, we've done it all.
Totally.
And sometimes, do take a very good look at your bonding procedure, because I think a lot of people don't rinse off the etch long enough. Like, give it a good 10 seconds.
You know what I heard in a lecture, and we've started doing this now, is they were talking about how the etch works, in that when you're etching on a cut surface of a tooth, there's a smear layer. There's the dentinal tubules, and the enamel is kind of like open for you to be able to let the etch kind of soak into the tooth. But if you're etching something directly on an unprepped surface, that the etch has a more challenging time kind of penetrating into the tooth, and so to leave the etch on for longer. So instead of doing, I can't remember what the ideal time, you guys out there probably know better than I do with prep.
Mine is 10 seconds, and I count. Can you imagine how many bond things I bond a day? Like, I count to 10 out loud.
Which is kind of pretty standard
because
protocol.
I'm fast. Like we're like, you do
Yeah.
things fast. So
Yeah.
I count to a good 10 and then I rinse the rinsing is super important. I rinse for the same 10.
And you know what I would do? I would probably do it the same way because I don't obviously do the bonds myself, but I would probably do something similar. And then if I found a button or something came off, I've heard and this is what I've had the assistants been doing, leave the etch on for even up to 60 seconds for the tooth that it came off on, because then it gets the etch to penetrate into the tooth more and kind of, it improves that etching process. Now, I don't know that there's any evidence-based literature that I have for that. And again, people out there might know better because when you're bonding, say, veneers, for example, and this is a great question, so feel free to comment on this, anybody who knows. How long do you etch a non-prep veneer for, would be my question.
Yeah.
Because
it seems like an eternity.
Because if that is now becoming the standard, that you are etching for longer, then that would be kind of potentially the solution for, I wouldn't worry about it with the attachments as much, but maybe just the buttons.
Yeah.
That giving that extra 60 seconds, if it keeps them on, that might make a difference.
Yeah. I know with my team, we kind of explain it like the longer the etch is on. And I mean, I know there's a thing is over etching. I don't know what that's about, but again, we're just trying to get our team to at least do the full, whatever the manufacturer says, at least the 10 seconds. But
totally.
It's taking all that material between the tubules away, and so it's like the prickly part of Velcro. So you want it to be as prickly as possible, not like all caught up with fluff, where it's ineffective, and then your bond is like the fuzzy part, and then that's a really good bond. Whether it's your lingual wires that are coming off or it's your buttons, the process.
Protocol is crucial.
Don't just like, if the blue disappears, you're not done.
I also like checking real quick when I'm actually involved with the process, doing a quick check, because sometimes you'll have a button cut out on like a buccal filling, and then you look at it, you should always be able to see that nice etch chalky appearance on the teeth. And sometimes you do have one that it's coming off, it's coming off. And then finally someone checks, or teach your assistants to look for the chalky appearance if they're the ones that are placing the attachments, or hygienists. Have them look to see if there's no chalk, then that means that maybe you put your button on a class 5 filling and you didn't realize it, and that's why it keeps coming off. Maybe you need to go ahead and use a hole punch tool or something to modify the trays and move it in a different spot on that tooth.
Exactly.
And that can play a role.
Okay, awesome. I think the only other thing we have is just wear instructions, which we did kind of go over a little bit. Again, you have different protocols we all have different protocols for different situations, but I think the takeaway is that, when you're doing it, you want it as close to 24/7 as possible, taking them out only to eat or drink, or in, some of your protocols where they're eating with them in. I mean, if you can eat with them in, go crazy.
Well, that's what I tell people with the elastics. Usually with a carrier, we do a lot of eating with aligners in our practice. Hygiene is paramount with that protocol, but things move faster. They're more efficient. Teeth get less wiggly because the trays are splinting them together like an orthodontic wire would. But we will tell patients, if they have a carrier, if you want to, try eating with them in. If you find that you're swallowing a lot of elastics, take them out. But if you can leave them in even when you're eating, go for it. Usually with teen and mixed dentition, I wouldn't, but usually I tell the adults that they can try at least. And
then you had mentioned don't be stingy with your elastics. Give them more than they need. So changing 5, 7, 8 times a day. If they want to change 12 times a day, don't be back in the mud. Just go.
Give them 7 bags of elastics. You want them, because people are going to lose their elastics.
Yeah.
And so we had assistants previously who were only giving 1 or 2 bags, and they're like, don't lose this. What are we paying per bag? $1 or something? Give them.
Put one in their lunch. I mean, growing kids, but you need one in the car, in your purse. You need them everywhere to make it convenient and become a habit. So set them up for success. Otherwise, you're going to get the excuse, well, I ran out. Your office is closed.
I don't have any.
That's silly. So get out of your own way and just give them the elastics. They paid for their treatment, and really you're saving time if they're wearing them. So to totally give those to them. I think that's, co-op with elastics. Just consistency. It's more about consistency than strength. So strength is great if you're inching your way up, but really it's just wearing them all the time, in my opinion.
Totally.
Okay, that's awesome. The only other thing, was just co-op and burnout, which we did talk about a bit as well. I think I think too, like in those new patient exams, when you have adults in particular who tell you who they are, and they're like, I'm not going to wear the elastics, I won't be good at that. We all try because we want that perfect outcome. But believe them when they tell you they're not that person. Come up with option 2 that doesn't involve elastics and let them choose. And I think it's great if you can convince them, or they're on the middle ground, they're not sure, because some people will do it for you. But if you really have that patient who, a lot of the times it's aesthetics, they're just not going to wear the elastics, and you've planned this huge sequential distalization or carrier, good luck.
You're wasting your time if you don't have compliance. And
now kids and teens, that's different. We should try.
Yes,
we should try. But again, if you get towards the end and it's mom at the end of the chair who's saying, yeah, give me more elastics, give me more, but she's not putting them on the child. So at a certain point, there's a conversation that has to be had with the mom and the child. But oftentimes at that point, it's the parent. We can't help you. We're not with you 24/7. So you got to kind of put it back.
Totally. So funny you saying that, because I just had a patient last week where I had like the case of 2 patients where they're both teens. They're both kind of at the end of their growth now, because they're probably like 15-ish as girls. Neither of them have been great with their elastics. The mom in the one case is like, the kid is done. Her teeth look great. Like, it looks aesthetically great, but she has an overjet. And I've talked to her many, many times, and talked to mom many, many times about wearing the elastics. They haven't. And so now we're ready to be done. It's probably going to take like at least a year of more elastic wear if they're going to continue on. Mom says like, no, we're going for perfection. We aren't going to stop. So now we're stuck in this position here where like the teen is not engaged. They're not interested. They don't care.
No.
I told my assistants right then and there, I'm like, I guarantee they're going to be back within 6 to 12 months. Nothing will have changed at all, because you're reading the personality. Whereas then I have another patient who is in with their mom. Same conversation, just that you have been wearing elastics. Your teeth are as straight as I can get them with the aligners. And the patient and mom are both like, you know what? We're realistic to the fact that she's not going to wear them. We're really happy with where things are at.
Yeah.
And so the goal is always, I love this quote, which is, treat kids and teens idealistically. Treat your adults realistically.
Yeah.
I think the second follow-up then should be, treat your kids and your teens idealistically, but it doesn't always mean that you will achieve those results. Right. Because even with brackets and wires, if they're not wearing their elastics, you're going to end up in the exact same position. Straight teeth, but no correction of their overjet.
And if you keep them in too long, whether it's aligners or brackets and wires, you're going to have consequences. You're going to have decal. It's just with aligners, you're going to end up, your alignment's going to be off, because eventually they're going to take those aligners out. So they're not wearing the elastics. Now they're not wearing their aligners. And now you've got relapse to deal with.
Now you're treating longer.
We do get responsible for.
Totally.
So it's better to like debond. And even if you tell the parents, after school or evenings, they can wear these, stronger aligners, and we know there's not going to be much change, but like, let them burn themselves out. They're already burnt out. So let mom burn herself out is basically, I am one of those moms.
It's true though. Sometimes we know more than the parents do, and you're kind of going through the motions, like with that one where it's like,
and you're just so worried about OHI, and also just like mentally, like it's just not nice to put someone through that, coming into your office and basically we're telling them, no improvement, no improvement, keep going. It's just demoralizing. So at a certain point, I think we got to help them out somehow. But anyways, but that was great. We learned a lot about elastics. I think that was fantastic. So hopefully it takes some of the fear out of using them. So you have another tool in your toolbox that you're not worried that you're going to make people's faces into like horses or
exactly.
These are things that I used to think about when my dentist started doing ortho, and I was like, oh my God, should we be doing this? Like people's faces, like I would have dreams about screwing people up, but these things don't happen.
And the reality is like we can have an impact sometimes for, like you were talking about Rob's case, right? Your husband. The differences in terms of the facial changes that we're making, both for the good and the bad, are really minor. We can't turn someone who has like a skeletal deformity into a perfect jawline, and we can't stop somebody who's got a really strong jaw. Like Richard Litt always said, the pattern is the pattern is the pattern. You can play a 2% role in that pattern, but you're still going to have someone with a retrognathic mandible if they've always had a retrognathic mandible. Someone with a prognathic mandible, they're always going to have it unless they do surgery. And so just recognizing that you're not going to, like Kelly was saying, where we think that like we have this huge potential to change their faces. Don't tell people that, like, you don't want to tell people that they can, but also realize that you aren't going to like screw someone's face up using rubber bands. There's a few spots, and we'll talk about with Carrier next time, but it's not like we're in this position where we can severely change someone's face in the negative or the positive.
Yeah, absolutely. So be cautious, but you can sleep
don't be scared.
at night.
Don't be scared.
If you use elastics, you can sleep at night.
Yeah,
Awesome.
Exactly.
Amazing. Okay, so I think our next podcast, I don't know if we're announcing what we're doing, but I think we're doing carriers, which is natural transition. So you'll know enough about elastics that you can bond those bars.
Yeah,
on both pieces of the puzzle.
Perfect. Cool. Awesome. Well, thank you, Kelly. Lots of fun.
Thank you. Fun afternoon.